All right. Well, good morning, everyone, and welcome to our webinar on the 2025 Medicare Physician Fee Schedule Final Rule. We're excited to have you here as we break down the major updates impacting primary care practices. And today's session will focus on important changes, including advanced primary care management, EM visit add-on codes, new modifiers, and much more. I'm Brian Esser, Principal Product Manager at Elation Health. Very nice to see you here. I'm working primarily on our billing product, Elation Billing. And at Elation Health, we're empowering physician groups and primary care doctors to deliver phenomenal patient care with our suite of tailored, clinical first, all in one solutions. And we've also had great success with our AI powered Scribe Note Assist. You can see that in my background here, allowing you to reclaim face time with patients and reduce after hours work. Be sure to look for the free in app trial and take it for a spin if you're a current user. Doing some due diligence here, want to remind you that this webinar is being recorded and we'll share the recording with you afterward. So don't worry if you miss something. Before I hand it over to our expert here, Kelly Schoenfeld, let me give you a quick walkthrough of today's agenda. We're going to start with the overview of the final rule. We're going to cover APCM codes, that's Advanced Primary Care Management, EM visit add-ons, post-operative care changes, telehealth updates, fee schedule adjustments, and more. A lot to cover today, but without delay, we're going to get right into it. We will wrap up with the Q&A session to address your questions. And in the meantime, you can look for the question mark chat bubble in your GoToMeeting webinar and drop your questions in there throughout the webinar, and we will do our best to answer them. Anything that we can't cover, we will reach out to you directly, but we would love to hear from you there. With that, I'm thrilled to introduce Kelly Schoenfeld, CEO of Zoo Health, one of Elation's preferred revenue cycle management partners. Kelly is bringing extensive experience in healthcare operations and revenue cycle management with more than a decade of experience. Elation users can also take advantage of Zoo Health's 2025 Easy Transition Program, offering 2 months of free RCM services. With that, Kelly, we really appreciate you being here, and I will pass it over to you so we can dive right in.
All right. Thank you for the wonderful introduction, Brian, and thank you everyone for attending today. As stated, we will be discussing the Medicare final rule for 2025. There's a lot to discuss, so let's go ahead and jump right in here. Each year, the Centers for Medicare and Medicaid Services, CMS, issues a final rule for Medicare programs, including the Physician Fee Schedule. The final rule addresses public comments on the proposed rule and updates the rule's estimated costs and benefits. To determine payment for a particular service, the Medicare Fee Schedule geographically adjusts relative value units, RVUs. I'm sure all the physicians in here are well acquainted with that. They reflect the physician work and costs of providing that service and then multiplies those RVUs by a dollar amount known as the Medicare conversion factor, also set by the CMS. So let's take a quick minute to define terms. This, I think, is probably the most boring part of the presentation. All the code stuff I'm most excited about, but do our diligence here. RVUs are calculated based on 3 components. The work RVU, this is the physician's technical skill, physical effort, mental effort, judgment, stress related to the patient outcome. The most crucial component is the time required to perform a service. The second one is the practice expense RVU, covers the overhead costs of running the practice, such as rent, equipment, supplies, staff salaries, basically, everything extraneous. Malpractice RVU is the third one, reflects the costs associated with professional liability. I'm sure most of you are paying for liability insurance, and you know how expensive that can get. Once the total RVU is calculated, it's multiplied by the conversion factor. Basically, conversion factor determines whether payments to physicians will go up or down, which we'll visit in a second. Also in play is the Medicare Economic Index, MEI. It's a measure used by CMS to estimate the annual changes in the cost of operating medical practice. It's a key component in determining medical or Medicare reimbursement rates for physicians and other healthcare providers. So how is that applied? The economic index typically factored in to Medicare's Physician Fee Schedule, often in conjunction with other legislative rules or cost containment measures like the conversion factor. While the MEI estimates cost changes, actual payment updates may be influenced by budget neutrality requirements or policy changes. Basically, under current law, the projected cost of all changes to the physician fee schedule must be budget neutral. That is, the changes may not raise total Medicare spending by more than $20 million in a year. The AMA is actually trying to work on that and fighting against that to raise that budget so reimbursement can go up for physicians. So we'll see how that plays out. But the bigger picture here, what's going on, what does it mean to me? The Medicare conversion factor for 2025 is $32.35. This is a 2.83% decrease from last year. So in other words, reimbursements for physicians are going down. Not good news, right? Even worse news, reimbursements have been decreasing for 5 straight years now. So this makes it more important than ever to make sure you're utilizing the new CPT codes that we did get from Medicare. Make sure you're billing for all procedures you're currently performing, and make sure you're aware of new revenue streams that may be available to you, such as chronic care management, remote patient monitoring. Those immediately come to mind. So with that, let's get into some of the new codes and some of the codes you probably aren't using, but you should consider. The first one of those is the Advanced Primary Care Management codes. See, that slide just came up. One of the most significant changes is these codes, G0556, 557, 558. These codes simplify payment by bundling care management services and reflect patient complexity rather than rigid time thresholds. The result is practices can reduce their administrative burden while ensuring fair compensation for their efforts. So these are new chronic care codes basically that aren't tied to a time limit. Some of you may know about chronic care management, and that code's 99490. That does have a time limit of at least 20 minutes. So this is kind of an alternative pathway because the first code, G0556, are patients that only have one chronic care condition. Generally, for CCM, you have to have at least 2. So they broke this into pieces, these 3 different codes. But so the first one chronic condition that's expected to last a significant amount of time, commonly at least a year or until the patient's death. These services are offered by clinical staff under the guidance of a physician or other qualified healthcare professional who acts as the main point contact. So what does that mean personally? I've seen practices use nurse practitioners to manage these chronic care patients. The code is billed per calendar month. So this is a monthly code, and right now reimbursement for that is right around $16. Of course, that's going to vary on where you're at, geographically. The second code in this bundle, G0557, are services for patients with more than one chronic condition. Generally, 2 at least or more that significantly increase their risk of serious complications or decline. This is also reported monthly, reflecting continuous team-based management of multiple chronic conditions. Reimbursement for this is right around $51. So that's not far off from 99490, which is about $63. And the last one, this is a kind of a special one that is looking at a patient's economic status, is G0558. Focuses on services specifically designed for Medicare beneficiaries who have multiple, so 2 or more chronic care conditions, and they're also a qualified Medicare beneficiary. So basically, to be eligible for that, you have to be entitled to Medicare Part A, have an income at or below 100% of the federal poverty level, and have resources at or below the Medicare Part D low income subsidy. So patients with limited financial resources have 2 or more conditions. Reimbursement on that is actually pretty decent, about $112 per usage of that code. So for these codes, and this is for all the billers out there, there are a couple of common errors that you should be aware of. You have to make sure there's no overlap that occurs with other care management codes for the same patient within the same month. These codes can only be billed once a month per patient. Medicare will deny your claim if you're overbilling it. You might even open the door to an audit. Nobody wants that, right? Do not bill CPT code 99490 along with this. That one is time-based and conflicts with the APCM codes. And then keep in mind, I think I mentioned earlier, 99490 requires the 20 minutes spent with the patient. That's not necessarily, for the rest of those APCM codes. So you need to follow payer-specific guidelines for monitoring, documentation, and reporting. Thorough documentation is critical, as errors or omissions can quickly lead to denied claims. This includes monthly clinical activities, transitions of care, care plan updates, patient interactions, and much like chronic care management, you have to provide 24/7 access for patients. So round-the-clock communication options. If you're working with anything like remote patient monitoring and you have, somebody has a heart rate of 150, somebody's going to need to contact that patient. So a lot of the chronic care requirements are also met with these codes. They just give you a little more flexibility. So the fees and reimbursement rates for these codes are higher due to the level of coordination required. However, Medicare and commercial insurers may have varying policies, so it's important to confirm coverage before billing. Also strongly recommended to let patients know of any potential cost-sharing obligations. For transparency, for example, G0558, the QMB, they may require a small Medicaid copay to let them know that ahead of time. But when you implement these codes, it may seem like reimbursement is not so much, but it quickly adds up. And we're here to help you add those dollars up. So even if you saw 200 patients in your population and billed the G0557, can quickly get over 10,000 a month, over 100,000 annually. So there's definitely a cumulative effect. And with that, let's move on to another exciting code, G2211. Got the slide up. This code was actually introduced in 2024. They've been playing around with it. Medicare has kind of changed some of the things involved with this code. Starting in 2025, it can be billed alongside a base EM code for visits that include preventive services. This is super, super important. So that's exams, labs, other tests and screenings in the office. G2211 serves as an add-on to existing EM services when patient needs go beyond routine care. So when can you use it? The associated EM service, so you're looking at those codes that are like, 99213, 214, 215, or, new patient visits. It's reported with modifier 25, but only if the additional service is a Medicare Part B preventive service. Previously, billing G2211 with a modifier 25 EM was not allowed. So they've changed things around a little bit with this. You are going to use the 25, but you've got to show these are additional separate services. So you also bill it when additional effort isn't accounted for by the standard EM. You're going above and beyond, but you got to make sure you're documenting this. When you're doing simple things like immunization administration, you can also plug that on. When you're providing ongoing care for serious conditions, say like glaucoma or age-related macular degeneration, also bill that. So here's like a little example of what you could bill in the office. You may be able to do, a 99213 and a G2211, and also bill for an annual wellness visit. So there's different configurations, all meant to put a little bit more money in your pocket to reward you for the extra work that you're doing in taking care of these patients. So when can't you use it? You can't use it when patient-provider relationship is not ongoing or the provider doesn't plan to take on ongoing care. The visit's a one-off, like a mole removal or consultation for an acute issue. Can't use it if the visit's an urgent care center visit, or if the visit's an inpatient emergency department, nursing home, or home setting visit. So to get paid for this, basically it's really important to document everything. You got to document the complexity, clearly outline the patient's condition, extra work involved in managing their care. So fees and reimbursement for this code. Medicare set an allowable rate for G2211 around $16. Once again, while this amount might seem modest, also a cumulative value, they add up. You're adding all these extra codes to your EM codes. You will feel that, and it's a nice way to get some extra bucks. So code G2211, more than just a billing line, opportunity to enhance your practice's revenue while ensuring your efforts in providing high quality care are recognized. Okay, so with that, we're going to go ahead and move on to the next code in the system, and that is G0559, and this will also be the first mention of a modifier. So this may not be relevant to your practice. It may be relevant to some of you out there that do perform surgeries. These are changes you need to know about. An adjustment to modifier 54 has been introduced to better reflect realistic care transitions. The transfer of care modifier 54 now applies to all 90-day global surgical packages, addressing situations where post-op care is handled by a different provider. Additionally, the new add-on code G0559 compensates providers who are following up care for surgical patients, ensuring their work is properly reimbursed. So, what is the code? Applies to post-op follow-up visits you provide when the surgery was performed by another practitioner outside your group. You're helping the patient's recovery during the standard 90-day global period. There's no formal transfer of care, meaning the original surgeon still holds primary responsibility for the patient's post-op course. The code captures the complexity of these visits, including reviewing surgical notes, examining the patient for procedure-specific complications, communicating with the operating surgeon as needed. By documenting these extra steps, you ensure proper reimbursement for the care you provide. When can you use it? If your post-surgical follow exam to a patient whose original surgery occurred within the past 90 days, the key requirements include a different practitioner. You or your group are distinct from the practitioner who had performed the surgery. No transfer of care. Original surgeon retains primary responsibility for post-op care management. You're within the 90-day global period. Visit must occur within the 90-day global period for the surgery. Added complexity, you performed a detailed evaluation, reviewed the surgical records, and addressed any complications or concerns. Medicare has some very specific scenarios where this code cannot be used. On the flip side of the coin here, same provider or group, that code is intended for a different practitioner than the one who performed the surgery. If you're part of the same group, this code doesn't apply. Transfer of care, you can't bill this code if you've fully taken over the patient's post-op management. Original surgeon must still be considered the primary person for that patient's follow-up care, or beyond 90 days. If the post-op visit occurs after the standard 90-day global period, the G0559 no longer applies. Normal evaluation and management codes are typically used instead. So to ensure successful reimbursement, be sure to document thoroughly, detail your post-op evaluation process, include notes about the surgery, patient exam findings, any communication with the original surgeon. Demonstrating the extra complexity just helps justify this code. Verify the global period, make sure you're in that 90-day window. You can use this G0559 with EM codes. So you bill them in addition to your standard office, outpatient evaluation, management visit code for the encounter. And of course, ensure there's no overlap in care responsibilities or formal transfer of care, which would disqualify the use. So the reimbursement on this is around $9. Like I said, some of these don't seem like much, but they'll add up if you're involved in these things, in these situations a lot. For any of you out there that may be hospitalists or have hospital privileges, you can bill this code with your normal inpatient CPT code. So you might see something like 99233 plus G0559. So this is something you could definitely put in your pocket and bill for. Modifier 54. This code has existed, but there's a significant change with it. Per 2025 Medicare Physician Fee Schedule, this 54 modifier will be required now for all 90-day global surgical packages when a practitioner only performs the surgical procedure portion, essentially mandating the use of transfer of care modifiers in all relevant scenarios. So key points about modifier: establishing a broader use of transfer of care modifiers. So those will include 54, 55, 56. These modifiers will be required for all 90-day global surgical packages when a practitioner only performs a part of the package, like pre-op, post-op, even if there isn't a formally documented transfer of care. So for modifier 54, that's for surgical care only, when one physician performs the procedure and another provides post-op, pre-op care. And then modifier 55 is, whoever the physician is that's doing the post-op management. So hopefully, this isn't too hard to follow. We're trying to keep this moving along, going kind of fast and furious because there's so much content to get to. So forgive me if it's going quick, but feel free to be asking questions in the chat there. And even if we can't get to you right away, we will get back to you if there are questions on that. Any case, it's going to get a little more complex because now we're going to talk about telehealth. And so we're finally changing the slide, moving up further here. There we go. Okay, so telehealth is going to be an interesting one because some of this is actually still in flight right now, and that's regarding originating sites. So the code in question is Q3014, involved in ongoing legislation. Key parts of this are: at the close of 2024, U.S. Congress passed the short-term extension of Medicare telehealth flexibilities as part of the American Relief Act. The Medicare telehealth waivers originally enacted in the first place was COVID-19. I'm sure everybody remembers that. And it was subsequently extended through legislation. All of that was set to end on December 31st of last year. So the ARA extended that, and currently now it's set to expire March 31st. So we'll see if they're working on that and they extend it, but basically people were going to have to report to originating sites instead of being able to conduct telehealth visits from their own place of residence. So the geographic restrictions and originating sites are important. If this does not get extended, patients' homes will, or if it does get extended, patients' homes will continue to serve as eligible sites. The geographic restrictions are going to be waived. The expanded definition of the term practitioner will continue to apply, and that definition includes occupational therapists, physical therapists, speech language pathologists, and audiologists. Also, they want to keep it where audio-only telehealth services remain eligible. Before, I think you might have had video component that was needed, but you can just do audio only. Telehealth services for federally qualified health centers and rural health clinics have been extended. And there's one really huge one for everybody that's involved in behavioral therapy. They were going to set the new requirement that needed to be in-person visits. but Congress has extended and waived the in-person requirement until April 1st. So basically, you need to see what Congress is going to do, see if they keep the status quo, which seems like it would be the easiest. Otherwise, code Q3014 represents, the telehealth originating site facility fee, and these facilities are going to have to take people in and be kind of the way spot for people to see the doctors that way. So the facilities that are originating sites, they have to be a private space for telehealth sessions. They have to have telecommunications technology, on-site staff support. The main reason of this new code is to ensure patients in rural and underserved areas can access high quality care without traveling long distances. So when can you use this code? Assuming that things don't get extended. Facilities can bill Q3014 when they serve as the originating site for a telehealth visit under the following conditions. Patient must be in a Medicare designated rural or underserved area. You have to verify eligibility using Medicare's geographic tools before submitting claims. You have to be approved originating site. It could be hospitals, clinics, health centers, nursing facilities. The patient's physical presence at the site is mandatory. Services must comply with Medicare's telehealth guidelines. And Medicare has specified that this code cannot be used if the patient accesses telehealth services from home or any location that does not meet Medicare's definition of an originating site. So yeah, there was a lot of uproar about this. People, are at home. They want to be, not have to leave the comfort of their home, still be able to see their physician. And so far, so good. That is staying in place. But just good to know this information in case that changes. For 2025, the reimbursement for this code is 80% of the lesser of the actual charge, or $31.01. So basically, it's going to be around $30 just to host these telehealth visits. So here's a few things to keep in mind. Most Medicare plans cover this code, but private insurers may have specific requirements, including the dreaded words prior authorization. So I'm sure everybody knows about prior auth. So you will have to have that. There's a cost sharing for patients. Medicare beneficiaries may have co-pays or deductibles for telehealth visits. Inform patients about potential out-of-pocket costs. You always want to collect co-pays up front, as I'm sure you know, and a lot of times insurances actually require that of you, and especially when it's telehealth. If you don't have the patient there, it's better to get that money in your pocket today than try to chase it tomorrow. So this code Q3014, if we get there, can be billed for each telehealth session, but excessive, unjustified billing may trigger audits or denials. So once again, be careful how you use that code. But this is a very much wait and see situation to see if things get extended. So the two deadlines we were looking at are March 31st generally, and behavioral health April 1st specifically. And so with that, let's keep cruising along and talk about cardiovascular risk assessment and management. Hope you guys are hanging in there with me okay. So these are two new codes, G0537, G0538. So 537 covers the standard cardiovascular risk assessment. This should last 5 to 15 minutes and billable just once per year. So this code supports early detection by looking at things you would expect, cholesterol, blood pressure, lifestyle factors, which helps guide measures and the targeted therapies that you give the patient. So G0538, that's not the annual one. This is kind of a monthly monitoring. So it focuses on The monthly cardiovascular risk management, covering medication adjustments, so if you're taking blood pressure meds up or down, lifestyle coaching, follow-ups, and ensures consistent care for patients with known cardiovascular risks. So when can you use them? Conveniently enough, you can use them with several of the codes we've already talked about. So patient comes in, you can bill for a 99214, the G code G2211, and you can also do this G0538 all together. And that's where I keep bringing up, there's a cumulative effect. These are all like little blocks you're putting together, and they're all dollars, and it's rewarding you for giving the patient excellent care, which I know that's all you care about, right? But you got to keep the doors open too. So G0537 is the initial risk detection. It's ideal during preventive or annual wellness visits. So that'll be, like G0439. I'm sure you guys know about that. And it's only billed annually as discussed. Reimbursement for this is right around $20. That's an approximation depending on, where you practice. G0538 is the ongoing management. So that's, your medication oversights, follow-ups designed for patients with ongoing risk who require routine touch points. The reimbursement for that's about $16. So you have to make sure your documentation clearly supports each code. To avoid denied claims, Medicare has specific scenarios where this code cannot be used. And they don't want you to exceed frequency limits, so G0531 once a year. Don't try to report it any more than that. Might be nice if you just set it up and had a reminder to do it at the top of each year. Just get it out of the way and get paid for it right in the middle of deductible season, which everybody loves. G0538, make sure that you're billing that monthly. You don't want to overlap with other monthly care codes unless there's a clear distinction in the activities performed. Any duplication of services, Medicare generally does not allow billing G0537 or 538 in the same period if those activities are already accounted for under another code. So once again, I'm bringing up chronic care management or remote patient monitoring. Some of those cover the same tasks, so you may not be able to report these codes separately. In a non-cardiovascular context, these codes are specifically addressing cardiovascular risk. So if your documentation is focusing on other conditions and not that, and it's not related, Medicare could deny the claim. As anything else, you will also need to look at your diagnoses codes to demonstrate medical necessity. So a patient that's a good qualifier for this might have chest pain, obesity, high blood pressure. You wouldn't necessarily want to have like a diagnosis code of a headache. You probably won't get paid for that, right? It makes perfect sense. Okay, so let's move on from that. Let's go to the caregiver training codes. And it looks like we got about 10 minutes, but I am trying to wrap this up. So the caregiver training codes are G0541, 542, and 543. And so when can you use them? So these are three codes related to scenarios where caregivers are being trained by the physician on, safe, practical measures to care for patients outside of a clinical setting. So it can be used in the following scenarios: face-to-face instruction. The provider or physician is teaching skills directly to the caregivers. Number two, patient should not be present. This focus is exclusively on teaching caregivers rather than providing direct patient care. Number three, extended sessions. G0542 is an add-on code, so any 15 minutes beyond the initial, you get to charge for that. And then the last piece of that is group training, which is the G0543, when the provider is instructing multiple caregivers in a single session. So the 541 covers the first 30 minutes, and those sessions focus on things like how to provide wound care, infection control, pressure ulcer prevention. The reimbursement for that is $54, so not too bad. 542, as I mentioned, additional 15 minutes, then you get to tack on another 26.50. And then G0543, where you're training group members, there's multiple caregivers, that one is $23.39. So these codes recognize the value of caregiver education, enabling you to deliver hands-on instruction that improves patient care, but you also have to capture reimbursement for your time. So make sure you document the session was caregiver focused and that the patient was not involved. Patient can't be involved. Don't forget to confirm that the training meets clinical guidelines for preventing complications and improving quality of life. Once again, there's always situations or scenarios where you cannot use these codes. So go through a few of those. The patient's present during training, cannot bill them if patient's there. There's no link to the patient condition, so you have to have training that's addressing the patient's documented needs to qualify. If there's inadequate documentation, claims require detailed records of time, techniques taught, and caregiver roles, so you must have all of that. Overlapping services, you can't bill this code alongside others, covering the same activities. And frequency limits. Some payers may impose limits or require prior auth. There's prior auth again for repeat sessions or group training. So moving right along, kind of wrapping up and summing up, APCM codes allow you to provide patients with a wide range of services to meet their individual needs based on complexity, and this is chronic care management without the time-based requirement. Billing for these services uses a monthly bundle instead of billing for each individual service or recording minute by minute. The G2211 is an add-on code, recognizes additional time and complexity involved in relationship-based care. So starting in 2025, it can be billed alongside the base EM code for visits. And mentioned this earlier, this is really important. It's all the preventive services like the exams, lab tests, screenings, all of those things are going on. And so you attach this code on to the EM code to get paid a little bit more appropriately. Modifier 54 and code G0559, those ones are all about physician surgeries and managing post-op care, pre-op care. And the cardiovascular codes we discussed, you have the two codes. One is general screening that you'll probably want to do at the top of the year. The G0538 is the one that you'll want to do on a monthly basis to follow along and just meds for patients. And the one we just discussed, the caregiver training codes, G0541 to 543, which outline the types of training that can be given, as well as the requirements and recommendations for billing them. Anyway, we're getting real close to the end here. Before we get to the Q&A portion, I'd like to thank all of you for attending today. You could have chosen to be anywhere else, but you made the effort to be here. I really appreciate that. And I know Elation Health does too. We care about you as customers. And if you're not a customer yet, we hope you join us, and I hope that's shining through. Please reach out if you need any help with your billing. I am always available to you. And with that, I'll hand it over to Brian for the Q&A portion.
Thank you so much, Kelly. Very much appreciate all the great information. As we knew, it was going to be jam-packed, so we do have limited time for questions. If we do not address your question, we will follow up via email after the webinar, so keep a lookout for that. So I will go ahead and rapid fire a few things to you. One is, can I bill the APCM codes and the chronic care management codes together?
No, you're going to have to pick one track or the other. So it'll be considered a duplication of service. So if your patients are mostly, if they have one condition or two conditions, or you have a lot of the qualified Medicare beneficiaries, you probably would like to go along with the APCM track. and that might be a good fit for you. But for those that are interested in chronic care management, there are partners that we work with, and those are all basically two conditions that are expected, to go to the end of the year or the end of the patient's life. Uh, that would be another track that you could do, but you can't do both. You have to pick one track because one's time based, the other is not. So it would be just a series of questions, like what's best for your practice, and we'd have to sort through that.
Okay, great. And I think one thing we can highlight is that while you have to choose either APCM or CCM for a patient, both of those can be combined with remote patient monitoring. So that's good to know. Uh, are APCM codes billed at the end of the month like the CCM? Um, I can answer that one. I believe they're billed at the beginning of the month, different from CCM.
Yeah, chronic care management is definitely at the end of the month. Generally, for that, we would get a report generated for all the codes, all the patients seen, and all the work done, and bill it at the end of the month. Give doctors the reports of what happened. And so, yeah, it's a little different. APCM, top of the month, chronic care management, back end of the month.
Okay, great. Question came through about the G codes. Are these G codes one time per month or per year? Uh, Looked like it was a mixed bag. Most of the G codes covered could be billed monthly. There was the cardiovascular screening code that was once per year, and G2211 separately can be used alongside regular EM codes. Also had a question about the difference of G2211 and G2212. Um, a quick highlight on that. G2212 is a time-based extension, where G2211 is about complexity in the context of longitudinal care and not just a uh, time extension.
Right.
So
Yeah. You got to look at some of those codes, especially when they're back to back. Like we talked about the caregiver training codes, like G0541 and then 542. Well, 541 is the first 30 minutes, and then tacking on 15 minutes is the next step up code, plus one. And I think that is the same thing for chronic care management, which we didn't go into, like, but 99490, I think additional minutes is something like 99439. And I got so many codes going through my head. But so, yeah, there's always the initial base code and then the extension of time code that you could put on. And so, like for G2211, G2212 is that. So.
so we had another question about can these codes be billed by NPs or only MDs?
Oh, okay. That's an interesting one. Some of these I specifically mentioned that practices will use NPs to manage their chronic care patients. Um, that's pretty standard. And there's, a whole Medicare rule too about billing incident to, which I'm sure most people out there know about. Generally, if an NP PA is submitting claims to the insurance companies take a reduction off of your reimbursement. So maybe the NP's PAs get paid at 80%. But if you follow the Medicare rules for incident two, you could bill at the physician level and not get any of that money cut out. So it's a really great situation because NPs, PAs can be really helping out with the practice, and they can be billing the codes, and you bill it in such a way that it's under supervision of the provider, so it's a win-win situation. But yeah, NPs and PAs can bill these codes, particularly if you're in a state where they allow full autonomy. I think we're just signing on a practice right now that's in Iowa where they do have that. So PAs and NPs are, uh, writing prescriptions, doing, most whatever a physician would do. Hopefully that answers.
So they're practicing independently. I think we got two more quick questions and we'll have to wrap up and definitely reach out for these other questions to the audience on email. So please look out for that. Um, we have an answer for this one too. Does providing patients with a phone number for a 24-hour answering service count as 24-hour care? The answer on that one was unfortunately no, not by itself. There must be access to a clinician. So the ways some people are accomplishing this are after hours nurse triage services, along with on-call clinician rotations. But a 24-hour answering service alone does not meet the requirement. Finally, Kelly, what resources would you suggest to help prepare and look further into these changes?
Oh yeah, it's a good question, and it's the answer is the same thing I use to prepare for this, presentation. Um, Going to Medicare directly, their website, they get cms.gov. They have options where you can sign up and get, daily newsletters. They let you know new activity, new codes, changes, to the rule for 2025, maybe updates on, what's going on with telehealth. That's a really good place to get information. Um, Also, another good place to get information is my website. It's zoo.health. There's no .com, zoo.health. And if you go on the expert advice section, you'll see all of these codes there. We have a lot of information there. We try to keep that updated regularly. We even have our own newsletter. We like to keep our providers well informed on what's happening. And of course, if you know what's happening and if you know what codes that you can, newly bill to increase revenues, we're all about that. We want, our practices to make more money, be successful, grow, keep the doors open, and take care of patients for sure. So I would go to cms.gov or go to zoo.health expert advice. You'll be able to find a lot of this information there.
Thank you very much. And these codes are active here starting 2025. Elation Billing has all these codes preloaded, ready for you to start billing them. So thank you all for joining us today. We appreciate your time. Would like to remind you to please reach out to us and we will also send you this recording. At Elation Health, we provide an all-in-one EHR and practice management solution designed for independent practices like yours. If you haven't checked out Notice Assist yet, by the way, again, you can sign up for a free trial directly in the application. If you're not already an Elation customer, I encourage you to book a demo with us at elationhealth.com/demo to see what Elation can do for your practice. And if you're considering medical billing services, Zoo Health is here to help. With their 2025 Easy Transition promotion, you can start improving your RCM with wildly efficient medical billing, getting your first 2 months free. You can contact Kelly at kelly@zoo.health or book a discovery call at go.zoo.health/elation. Thanks again for joining us. We look forward to helping your practice thrive in 2025.